we are going to discuss about the symptomatology in cardiac diseases, and we will start over this based on a case discussion. This is based on a case of a 22-year-old female who is a resident of Bihar who is studying BA and presented with the chief complaints of shortness of breath for 2 years, palpitations for 2 years, abdominal distension for 1.5 years, yellowish discoloration of eyes for 1.5 years, and swelling of both the feet for 4 months. So basically, this case has all the typical symptoms of a cardiac disease. We know there are 5 cardinal symptoms, that is dyspnea, palpitation, chest pain, syncope, and fatigue. So most of the cardinal symptoms are present in this case. I will discuss each of the symptom in the next few slides, but let's go to this case at the beginning. So a 22-year female who has all the typical symptoms of shortness of breath, palpitation, abdominal distension, yellowish discoloration, and swelling of both the feet. Now, the patient was apparently well till 2 years ago when she initially started feeling breathless after walking for about 1 kilometer and needed to take rest to continue the further. This gradually progressed in next 2 months that she was unable to walk for more than 10 to 15 steps without feeling breathless, and this was associated with orthopnea. Now, first important point is based on dyspnea. Now, whenever you tell a patient about a history of dyspnea, you should always ask what the work the patient is doing. Suppose he is an agriculturist and all, what is the normal work which he can do, and you have to tell based on NYHA. I will come to it further. So the patient was initially in NYHA 1 or 2, and then gradually progressed over NYHA 2, 3, and 4. So you have to ask the level of activity which the patient was doing in the past, and when he presented to you, how much there was a deterioration. Now, whenever you ask dyspnea, you should always, if the only symptom is dyspnea, you should always rule out whether it's a respiratory or it's a cardiac cause of dyspnea. So there are various other things like a history of progressive dyspnea, or a history of wheezing, or a wheezing, or a history of cough, dry cough, or cough with expectoration. A history of family history is important. A history of allergy is important. And then we will come to the other symptoms like orthopnea and PND. So the most important thing is how you take the history of dyspnea. You should always ask patient how much he was able to do before and how much he is able to do now. Now, whenever you ask a history of dyspnea, the next symptom with dyspnea is always a orthopnea and a PND. So orthopnea we know is dyspnea in lying down. I'll come to this things in the further. So I'll go to the history first. So there was associated orthopnea in this case. Now, whenever orthopnea is there, you have to ask the history of PND. So paroxysmal nocturnal dyspnea is something which you should always ask. And how do you ask PND is when the patient goes to sleep after sleeping for about 2 to 3 hours at around midnight, 1 o'clock, whether the patient gets up with air hunger or gets up with cough and sputum, and then he goes near the window or he sits down, and then the symptoms will be better. So the PND is very important history because it is very sensitive for left heart disease. A patient with orthopnea can have many differential diagnoses, but a patient with PND will have only one differential diagnosis, that is left ventricular failure. Now, whenever you ask this, the next thing you should always ask the other history which is related to the left side symptom, that is any hoarseness of voice is there, that is Ortner syndrome, or there is any history of any hemoptysis. And then you come to the right heart symptoms like the pedal edema or the ascites or decreased urine output or the facial puffiness and other symptoms. Now we have asked the history of breathlessness. Now there is no history of chest pain and there is no history of syncope in this case. There was no history of any fever, any weight loss, any small joint pain, chronic diarrhea, and any injection or drug abuse. Now, why this history is important? Because in all cardiac cases, there has to be a negative history. The negative history we ask because whenever the patient with fever, now fever in cardiac disease is very important. Now, there are various cardiac disease which can present with fever, like acute rheumatic fever. One of the most important diagnoses in this age is acute rheumatic fever. So you should always ask history of fever in a cardiac disease. Now, always people will ask you what are the other causes of fever in cardiac disease. So you should remember the common cause like rheumatic fever, infectoendocarditis. You should always remember in acute MI, like a patient who has pericarditis can have, or a patient who has a drug fever. Drug fever can be there. Connective tissue disorders can many like SLE, Libman's, endocarditis, those type of things you should always remember, or a collagen vascular diseases. So these are the various causes, or a tuberculosis causing myocarditis or a sarcoidosis with cardiac manifestation. So a fever history is very important, or sometimes a patient with cyanotic congenital heart disease can present with brain abscess and all. So that is also important. In children, when the fever is there, you should always remember things like Kawasaki disease and all, and associated lower respiratory infection in case of cyanotic congenital heart disease. So fever has very important aspect in history, cardiac history. Now, history of weight loss. The history of weight loss is not very important. Things like cardiac cachexia, when you have specific right heart failure, and which causes cachexia due to tumor necrosis factor and interleukins, it may cause cardiac cachexia, which can cause weight loss, or other things like a diuretic therapy. That is also important. However, if a patient has tuberculosis and all weight loss, which can present with cardiac manifestations like a pericardial effusion or a pericarditis or a myocarditis, then the history of weight loss is important. Now, small joint pain, though not very important, it helps in your differential diagnosis of acute rheumatic fever. Like a patient with acute rheumatic fever usually have large joint, which is migratory and polyarthritis. However, small joint pain helps to differentiate this from the other differential diagnosis of acute rheumatic fever, like a gonococcal, any arthritis, or a acute streptococcal arthritis. So there are various differential diagnoses of acute rheumatic fever joint pain we should always rule out. Chronic diarrhea, again, because the history of fever is there, and injection drug abuse, you should always remember. Now, coming to the past history, before that there was no other apart from this, there was a history of palpitations, which you should always ask about the important 5 to 6 important points in palpitation. I'll come to it, but I'll again just mention, whenever you ask a history of palpitation, you should always remember to ask whether it is regular or irregular. First point, it is slow or fast. Its onset is important. It's sudden onset or it's gradual onset. Then its offset is important, whether its offset is very fast or its offset is very slow, whether any Valsalva maneuver or a vagal maneuver patient has to do to reduce the palpitation. Then you should always ask whether it's exertional or it is at rest. At rest means it is due to arrhythmias. At exertion mostly means it is due to volume overload like a regurgitant lesion. Whether there is a post palpitation diuresis, which is usually due to atrial natriuretic peptide. And then you should always ask whether the palpitations, there are other associated symptoms like chest pain, which tells there is underlying MI due to palpitation, or a syncope. A syncope with palpitation usually tells that the palpitation are due to significant arrhythmias like a ventricular tachycardia, or rarely pheochromocytoma can cause syncope, or a LV dysfunction with severe congestive cardiac failure. These are the various points you have to ask in palpitation apart from drug history, like a withdrawal of beta blockers. It can cause arrhythmias, it can cause palpitation, it can cause various other things, or it can precipitate a coronary artery disease. Also, you should ask inhalation of beta agonists like a nebulizations, history of caffeine, use of alcohol, or even a alcohol withdrawal. Both of this can cause palpitation. So though I'll come to that palpitation later, you should always remember that based on your history, you can actually tell that the palpitation is due to arrhythmia, or the palpitation is due to cardiac diseases like a regurgitant lesion, based only on that thing, that whether it is exertional or it is due at rest. Now, abdominal distension. Now, this is one important history, that abdominal distension for 1.5 years. When the patient tells abdominal distension, the most important thing which should come to your mind is two things. One, a right heart failure due to a left heart disease. Second, a patient has a right heart failure due to organic right heart valve disease. Third, it is due to a pericardial disease. Now these three things are very important. I will just tell the important thing in that is, if it is due to a left heart disease, patient will initially give a history of dyspnea on exertion, will give a history of orthopnea, will give a history of PND, and then over a period of next few months, the symptoms of right heart failure will start. Now, the important thing is, once the right heart failure set in, the symptoms of dyspnea will usually disappear. So this is one important thing. In a patient of left heart disease like a mitral stenosis, once he develops pulmonary artery hypertension and right heart failure, the dyspnea usually disappears. Now, second thing is not only this organic mitral valve disease causing functional tricuspid regurgitation, PH and tricuspid regurgitation causes right heart failure, but organic tricuspid stenosis and organic tricuspid regurgitation usually causes abdominal distension. And also second important differential is organic tricuspid stenosis and tricuspid regurgitation. The third important differential remains your pericardial disease like constrictive pericarditis. Now, one important thing is when you have a patient with constrictive pericarditis, symptoms of dyspnea is usually less. They will have predominantly fatigue and right heart failure based on ascites. The first thing to come is usually ascites, which is known as ascites precox. As you would have heard, ascites precox is ascites due to constrictive pericarditis, which appears first and usually the only predominant symptom of constrictive pericarditis. There are various mechanisms. The exact mechanism is not known, but many say that there are hepatic constrictors which compress that vein, and then it causes constriction occurs around the hepatic constrictors, which usually cause ascites. So that is the third important differential. There are few other differential of abdominal distension in cardiac disease like restrictive cardiomyopathy, then rarely things like arrhythmogenic right ventricular dysplasia. It can also cause abdominal distension. And then the primary pulmonary hypertension. If a patient has primary pulmonary hypertension or any form of pulmonary hypertension, the predominant symptom sometimes remains abdominal distension. Now, yellow is discoloration of eyes for 1.5 years. Now, jaundice, though neglected, is one of the under diagnosed symptom of a cardiac disease. Now, there are few cardiac disease which can present with jaundice. The most important thing is cardiac cirrhosis. Now, because this patient has abdominal distension for so many years, the patient would have developed a cardiac cirrhosis and so have developed a jaundice. Other differentials of jaundice in a cardiac disease are uh, pulmonary infarction, infective endocarditis itself can cause, and sometimes your things like prosthetic valve. A patient who has a prosthetic valve, when they have hemolysis of a prosthetic valve, which can cause jaundice. So prosthetic valve, infective endocarditis, pulmonary infarction, and cardiac cirrhosis. Now, invariably, this patient have developed pedal edema, that is swelling of both the feet for 4 months. So this is how you have to analyze this history based on this. Now, going to the past history, this patient at 5 years of age had a history of swelling associated with pain in her large joint on both the side. This lasted for about 6 months, and she was then evaluated for the same by a doctor who told her family that she has a cardiac problem and was advised to take injection for every 3 weeks and some oral medication. Now, as I already told you, this patient is now giving a typical history of rheumatic fever. So the large joints are involved. That is the most common joints which are involved is first is the knee, then you have elbow, you can have ankle, and then rare the joints like hips and vertebra usually do not involve. Usually the temporomandibular joint are not involved. So mainly knee, ankle, uh, your elbow, and hips rarely can be involved. Small joints are usually spared in rheumatic fever. That is what you have to know. One more thing about the joint involvement, you should always ask the history of polymigratory arthritis. That is, once the patient develops the symptom in other joint, the ipsilateral joint, the symptoms will go off. So this is known as migratory polyarthritis. You should always ask this history. And did the patient take any painkillers or any aspirin or NSAIDs? Because one of the important thing about the arthritis in rheumatic fever is it it has a very good response to NSAIDs and aspirin. So it will go usually in 2 to 4 weeks, and even if you don't take, it will usually resolve very fast. So this is one important history of rheumatic fever arthritis. Now, when you have asked for about the rheumatic fever arthritis, you should always ask the history of sore throat. Now, only one third of the patient gives a history of sore throat. That is the painful swallowing, or a history of fever at that time, or a history of any tonsillar, any granular, those things. So you should always ask whether a history of throat infection is there or not. And then the thing which is very rare to happen but still can happen in abnormal movement, that is Sydenham's chorea. Though you may not get classically this history in from most of the patient, but you should always ask this history of abnormal movements and any skin lesions, that is erythema marginatum, this history. But those histories are very difficult because even the patient may not remember, and most of it is very less than 3% usually get this manifestation. Now the most important is history of penicillin. You should always ask whether the patient is on IM penicillin once in 3 weeks, because once the patient is on IM penicillin, your most of the diagnosis of a rheumatic heart disease is made. But you should, apart from IM, you should always ask the patient either oral penicillin he was taking. Many patients may not be taking IM but may be taking oral prophylaxis, which is not as efficient as an IM injection. And any other drug history whether the patient is giving, like a diuretics or a warfarin or any other beta blockers, those things. Now, family history is important in cardiac disease because of many things. One, first important thing is the family history of coronary artery disease. Though not relevant to this case, you should always ask any family history of coronary artery disease. If in males, in somebody is giving that in his family, among the male there is a premature cardiac death before the age of 55 in males and before 45 in female, that is a premature coronary artery disease. Apart from the normal and history of diabetes or hypertension in the family, also you should ask a family history of some cardiomyopathies like hypertrophic cardiomyopathy, which usually runs in families. Some arrhythmias also have family history like Brugada syndrome or arrhythmogenic right ventricular dysplasia. So this is the importance of family history in a cardiac disease, or a family history of sudden cardiac death. So this should always be asked in all the patient in a cardiac case. Now, personal history. Since 5 years of age, she was taking injection once every 3 weeks for about 2 years, and after that, she was irregular with injection. Since the last 2 years, she has been taking medications for symptomatic relief from general practitioner. So, the personal history, apart from this your diabetes, hypertension, history of smoking, history of tobacco, or a history of alcohol, the history related to this, what she was taking is also important. And you should always ask the history of socioeconomic status, because rheumatic fever is one thing which is usually predominant in low socioeconomic status. So if you have some grading like a modified Kupuswamy classification, you can ask the kacha house or a pakka house and what is the low income status. You can also add on to your history in a cardiac history. Now, apart from this, you should always take a negative history like a history of cough, expectoration, and wheeze. As I already discussed, if a patient only symptom is dyspnea, then you should always rule out whether it is respiratory or it is cardiac. Respiratory, like patient will give a family history, patient will have a predominantly dry cough or cough with expectoration, history of wheezing, atopy, usually PND history will never be there. Orthopnea can be there in cases like a pleural effusion and all can have orthopnea. Diaphragmatic palsy can have orthopnea. So those things are usually important. Then abdominal pain and diarrhea, you should always rule out. Involuntary movement, as I already discussed, and weakness of the limb. Now, why weakness of the limb is important in cardiac diseases? Most common rheumatic heart disease like mitral stenosis, in AF or most commonly in atrial fibrillation, they are predisposed to stroke. However, even in sinus rhythm, because of underlying vegetation or infective endocarditis, or when in sinus rhythm, many mitral stenosis can have a stroke. So, history of CVA is very important in a patient with rheumatic heart or a valvular heart disease. Not only this, patients with cardiomyopathy who has LV clot, they can also have a cardioembolic stroke. So it also tells that the underlying LV dysfunction or LV clot is there or not. In cyanotic congenital heart disease, stroke tells that there is a cyanotic congenital heart disease with polycythemia. Polycythemia can predispose to infarction or sometimes brain abscess in a patient with cyanotic congenital heart disease. Can have even if a patient has infective endocarditis, that can predispose to stroke. So these are the various relevance of stroke in a patient with cardiac disease and various vision issues. Also, you should also ask the history of peripheral artery disease, like any history of claudication and all, because two things: patient with mitral stenosis and AF can have a peripheral artery disease. Two, A peripheral artery disease means a patient may have an underlying coronary artery disease, because the vascular disease in one part of the body always predisposed to a vascular disease in other part of the body. So that history is also important. Now, when you ask the history, the second important thing is, after history, you should summarize. Now, summary is not the differential diagnosis, as I will come next. Summary is, you should always tell a 22-year male or 22-year female, educated or illiterate, whatever, with predominant or with a past history. If you think there is a past history of diabetes, hypertension is there, or if you think in this case with the underlying history of rheumatic prophylaxis taking for so many years, now presented with breathlessness, abdominal distension, palpitation, and pedal edema. So this is how you have to summarize. You should not tell the entire history in summary, but the important points like this year, male or female, with underlying either a diabetes, hypertension, or a underlying rheumatic prophylaxis, now presented with this symptom. So my next thing is, at the end of history, what will be your differential diagnosis? Now, in this case, I just kept it as an easy case because it is very easy to make a differential in this case. Like a patient has all the symptoms, but the most catching point I think you should understand is, this is a 22-year female who has this. So a 22-year female who is giving a history of rheumatic prophylaxis, before telling it's a rheumatic, yeah, it is a rheumatic heart disease, but you should always tell it's a juvenile mitral stenosis. Now, mitral stenosis we know most commonly present in the third or fourth decade. Presenting in the second decade too early, that is 22 years, is very usually not very unlikely, but it is very difficult to explain, because from the onset of rheumatic fever, it takes 19 years for the establishing a established rheumatic heart disease, which is usually very weird in this case. So this case is usually a case of juvenile mitral stenosis. Now, what is juvenile mitral stenosis? Patient develop mitral stenosis before the second decade. The mean age is 19 years. So at no very not very important at your level, but you should always remember juvenile mitral stenosis, like a congenital mitral stenosis, is a condition which exists. So patient had dyspnea, then the patient developed palpitation, right heart failure symptom, pedal edema, and everything. So this typically sets in a case of rheumatic heart disease, that is mitral stenosis. Now I will just discuss important thing, though not relevant in this case. A patient who presents with you with dyspnea and palpitation. Suppose this is a case of a 40 or 50-year male or female who presents with dyspnea and palpitation. Always mitral stenosis has to be in a picture. A patient who has a who is giving a history of long on dyspnea, 10 to 15 years, and who is having an underlying history of rheumatic heart disease, always consider left sided inflow obstruction like a mitral valve the first differential, whatever be the other symptoms like palpitation, angina, syncope, fatigue. Because mitral stenosis is the most common valvular involvement in our country, and out of 100, if you tell 8 times mitral stenosis, you will be correct. So mitral stenosis, when you tell you, then your patient has palpitation. Now, how do you explain palpitation in your case? Now, palpitation can occur in mitral stenosis, we know, because of atrial fibrillation. But based on your history, as I already told you, it is a arrhythmic type of palpitation, or it is a volume overload type of palpitation. If you think patient has a volume overload type of palpitation, always get a history of mitral regurgitation in your case. So it becomes a mixed valvular disease. Now, there is a difference between a mixed valvular disease and a multivalvular disease. Suppose this case has a patient has stenosis and regurgitant in the same valve, it is known as mixed valvular. Suppose this patient has more than one valve, like in mitral and tricuspid, mitral and aortic, it becomes a multivalvular. So there is a slight difference between these terms which you should remember. Now, suppose patient gives a history of angina, syncope, then you should try to get in aortic valve. Patient with angina usually will have a aortic valve involvement, like aortic stenosis. Aortic regurgitation can have nocturnal angina, but always try to get in aortic stenosis when you have an angina and a syncope together. So based on various combinations of your symptom, you should try to make a diagnosis of multivalvular. Now, suppose this patient has only history of dyspnea, a 40-year female presents with dyspnea, The first diagnosis will be a mitral valve, that is a rheumatic heart disease. The second diagnosis, you should, after that, you should start thinking of five. The cardiac diagnoses are usually five. Five cardinal symptoms, five diagnoses. First is rheumatic heart disease. Second is ischemic heart disease. Third is congenital heart disease. Fourth is cardiomyopathy. And fifth is pericardial disease. Your cardiac diagnosis will be only based on this five differential. So rheumatic heart disease, we told it will always be the first differential. Cardiomyopathy next. Now, can this patient, not this patient, suppose a 40-year male or female presents with dyspnea, and you have to make a differential diagnosis. Cardiomyopathy, there are three important cardiomyopathies, like a dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. Now, out of this, if the only symptom is dyspnea, I will consider a diagnosis of hypertrophic cardiomyopathy. Why? The most common symptom of a hypertrophic cardiomyopathy is dyspnea. Why? Because they usually have diastolic dysfunction, and also the most common symptoms remain dyspnea. Why not dilated cardiomyopathy? Because most of the dilated cardiomyopathy will, over a period of 10 years, progress to right heart failure, pedal edema, and their natural history is very poor. They may not survive for 10 years after the first diagnosis, and they will always have orthopnea, pedal edema. So they are not usually a preserved patient in 10 years, unlike a hypertrophic cardiomyopathy. And if I have a hypertrophic cardiomyopathy, I will always like to ask the history of any family history of sudden cardiac death. I will always ask, when does his dyspnea, also the history of angina and syncope. Because like aortic stenosis, hypertrophic cardiomyopathy can have angina, can have syncope. So when will his syncope precipitated? Usually we know there is a dynamic LVOTO because of the SAM. So anything which decreases the preload, like history of dehydration, history of fever, or after a bout of alcohol, so this patient usually have syncope. We know usually syncope is exertional in aortic stenosis, and it is post-exertional in hypertrophic cardiomyopathy. This is one of the important differentiating point between AS and HCM. AS doesn't give a family history, HCM may give a family history. It is usually exertional in AS, it is usually post-exertional in HCM, apart from the clinical examination, which we may discuss in next few classes. Now, why not restrictive cardiomyopathy? As I already told, restrictive cardiomyopathy is typically a right heart involvement. Patient may present with pedal edema, fatigue, abdominal distension, ascites, those things. So it is not a left heart disease which is common, it is a right heart involvement which is common. The third differential which I will consider in a 40-year old is not a ischemic heart disease but a congenital heart disease. We know without cyanosis, the important congenital heart diseases are pre-tricuspid or post-tricuspid. The pre-tricuspid are atrial septal defect, and the post-tricuspid are ventricular septal defect and patent ductus arteriosus. Now, usually the pre-tricuspid ASD usually presents in second to or a fourth decade, because the RV compliance is good. It is usually pre-tricuspid, and RV is a very compliant chamber. So it takes time for the RV to dilate and be hypertrophy. And that is why ASD are usually fourth decade, when they develop hypertension, when they develop ischemic heart disease or a arrhythmias like atrial fibrillation. That is the time they usually get symptom, unlike a VSD and PDA, which usually manifest in second decade. So this is one important history. Next is will be a ischemic heart disease, because this patient may not have a risk factor like family history, smoking, alcoholic, or a diabetes, hypertension. A 40-year-old with only dyspnea, unless dyspnea is an anginal equivalent. We will discuss what are the various anginal equivalents, like a dyspnea, diaphoresis, sweating, or a vomiting. These are various anginal equivalent, but a 40-year-old may present, but usually won't be up in the list. And lastly, pericardial diseases. Only with dyspnea the pericardial disease may not present. So these are the various differential diagnoses I will consider, and this is how you have to make a differential diagnosis at the end of the history. Now I would like to just stop here for 5 minutes. Any question I would like to take?
Sir, at history level, can you you told to we can differentiate between aortic stenosis and hypertrophic cardiomyopathy, no, sir?
You may be, means it is very
Yeah.
difficult, but at the end of the history,
Mm.
normally when a case of aortic stenosis is there, we usually make the diagnosis of LVOTO, left ventricular outflow tract obstruction. So it is
Yes.
very difficult to tell unless the patient is a young person who gives a family history of sudden cardiac death, or who tells that there is a history of when after a binge of alcohol or after dehydration, and that time they usually have a syncope. So if a patient has a history of suppose dyspnea, chest pain and syncope, my first differential for a 40-year male will be a
Yes.
dynamic LVOTO, but for a 70-year male my diagnosis will be a fixed LVOTO, that is aortic stenosis.
Yes. Yes.
History, the important points are this: family history and the exertional or a post exertional syncope.
Yes. Yes. Post exertional means after, means how many
Yeah,
minutes?
means not during the exertion. After the
Yes.
exertion, when the patient sits, there is a sudden
Uh,
decrease in systemic vascular resistance, which
uh,
causes
uh,
a
uh.
LVOTO, means SAM, systolic anterior
Okay.
motion, and then the patient may get a syncope.
Okay, sir. Okay, sir. Okay. Thank you, sir.
Sir, one question.
Yeah,
So like in cardiac history, usually there's sudden decompensation. Usually, if there is a long-term history, there will be some event which cause sudden decompensation.
right, right,
So
right.
sometimes what consultants say, like you start the history only with the sudden decompensation part, and you tell the like long-term history in the past history, which is better way. So like
I think
some consultant.
suppose a patient has a history of dyspnea, patient has a 10 years history of dyspnea, you can start with the patient had a history of dyspnea. Now the patient current admission, either you can tell that patient presented with us with the symptom of acute heart failure or sudden onset breathlessness, and then you can tell about this history, and in the past history you can tell the 10 years. Or there is a second way, as you told, you can give the patient has a history of dyspnea from 10 years. See, there is both way are right, there is nothing which is wrong, and at your level I don't think anybody will make a telling that it is a gross mistake. But it is always good when you tell chief complaint from the present admission, because the patient has now presented to you with the present symptom and not with the old 10 years back symptom. That is one important thing. The patient, if suppose the patient of a corona heart disease present with you with fever, you won't tell that my patient has a history of dyspnea for 10 years. You will always tell that my patient has presented with to me with fever for 2 days and not a dyspnea of 10
Okay.
years. So it is okay if you present that there is a history of sudden onset breathlessness, and then you tell that going back to the past history, it all started with 10 years back.
Okay. So
So
one more if
this is one important history. You raised a good point. You should always ask for there are 10 precipitants of a acute chronic heart failure, the most important being infection. So you should always ask a history of any fever or any sepsis, because the most common is the infection. The second most common is the atrial fibrillation. So you have to ask the history of any palpitation is there or not. And then you should, third thing you should ask a history of drug compliance, if there is a drug compliance is there or not. Fourth is salt and diet compliance. And then the important things are patient has any anemia or pregnancy or hyperthyroid or a thyrotoxicosis. Then you should always ask whether any ischemia has precipitated the heart failure. Then any rheumatic activity in a patient with underlying rheumatic heart disease, even an acute rheumatic fever or acute rheumatic activity can precipitate a heart failure. Then any myocarditis or any LV dysfunction as their acute rheumatic myocarditis has precipitated a heart failure. And rarely a binge of alcohol can precipitate, or rarely an acute pulmonary embolism can precipitate. So these are the 10 precipitants of a heart failure in a patient who is a known case of compensated chronic heart failure.
okay, sir.
Yeah, Dr. Sudhakar, if it's okay, I will also like to add something.
Yeah,
Dr. Rajat, what you ask is very relevant. In rounds, this happens. We start presenting case with 10 years, 5 years, 7 years, and it always consultant tells no what brought patient to the hospital is the chief complaint. So in a way, they are correct, but in exam you get another kind of scenario where actually cases are called just for exam. They are stable disease patient. So there sometime you can tell that patient has presented for follow-up, but his symptoms are this, and then you can start building up case. This is going to happen for sure in final year exam, where very stable patients are called of rheumatic heart disease who are on treatment and they are actually in well compensation. So as such, they do not have much symptoms. Sometimes they might tell that sir called me to come here for just for exam. So that can't be chief complaint. But you can start that patient is on follow-up with this, and he has presented for his routine visit. In his history, the cardinal or the chief complaints are this, this, and this. In chronology, you can start. But if there is acute decompensation, as you mentioned, you start that episode, and then after that you can go that on top of that patient cardinal manifestation. Then you have to start from like the starting point. It will work best.
And so penicillin history again, if whether to say drug history or chief complaint,
drug
we can
history,
like
drug history only.
Drug history.
Drug history. If you bring it to chief complaint, then means you are biasing from starting. You are dealing with rheumatic heart disease, right? So better we keep it as a hidden part there, and then we use it to our clues. Yeah. Any other doubt before we go for cardinal manifestation? Even a silliest doubt is fine. Okay, so it is always better to ask. For me also, this mixed valvular, multivalvular was something new I missed in my MD, I think. So it's always better to learn things. But if any doubt is there, you can always ask. It's completely fine. Later on also, Dr. Sudhakar is there in our group. So you can post doubts. He will clear. And one more thing, what actually I was expecting from you people, he cleared today. Constrictive pericarditis and ascites precox, right? So I will send the exact image which can explain a possible way for them. And I think Sudhakar sir, we can go with the cardinal manifestation.
Yeah,
and
if so no more question, I'll proceed with the.
Yeah, sure.
So after a differential diagnosis, I think you will go to the mostly the next is usually examination, but this time let's discuss the cardinal manifestation. Now, the first important cardinal manifestation, which most of the patient present with you, is dyspnea. Now, before going to this, the two important things are dyspnea and fatigue. Most of the patient, they may not know. So they may have confused themselves with the dyspnea and fatigue, and you may not be able also to extract the actually whether the patient has a fatigue or whether has a dyspnea. Now, the most important thing at your level which you should know is dyspnea is a central phenomena, whereas a fatigue is a peripheral phenomena. Because the dyspnea, most of the mechanisms are related to the receptors at the central level, and fatigue is usually related to the mechanisms at the skeletal muscle level. So dyspnea is a central phenomena and fatigue is a peripheral phenomena. Now, when somebody asks you a history of dyspnea, I know 99% of you will tell the abnormal awareness of one's own breathing, which is not actually wrong. It is a correct definition. However, if somebody wants you to give a scientific definition, that is what is given in Harrison, and that is what is told by the American Thoracic Society. I think you would have already had in your previous classes. It is a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. The experience derives from interactions among multiple physiological, psychological, social, and environmental factors, and may induce the secondary physiological and behavioral responses. So if you can remember this definition, it's good. But even if you don't tell, you can just quote that there is a definition, but it's an abnormal awareness of one's own breathing. So that is what is known as dyspnea. Now, dyspnea, as I already told in the history, the patient may only present with you with a dyspnea, and then the examiner will ask you why you are jumping to a cardiac diagnosis, because many a times somebody would have told you it's a cardiac case, and then you will tell, no sir, it's a mitral stenosis, it's a cardiomyopathy, it's a pulmonary hypertension. But how do you distinguish? Now, there are various things, like as I already told you, the dyspnea of respiratory may not be very easy, but sometimes it becomes because of other symptoms like a cough or a progressive dyspnea, history of weight loss, and then a family history and all. So there it becomes easy to differentiate a pulmonary cause from a cardiac cause. Or if somebody has already told his patient that you have a history of cardiac disease, history of rheumatic fever and on drug, then it is easier for you to differentiate the cardiac and pulmonary cause. Anemia is one thing which can mimic any cardiac symptoms. Trust me, a patient with severe anemia will sometimes you may tell that there is a severe aortic stenosis. Why? Because anemia is something which can mimic. It can produce loud S1, it can produce loud S2, it can produce murmurs across various semilunar valves, it can produce flow murmurs. So anemia can cause cardiomegaly, and you may tell that there is a down and out apex, and so there is a mitral regurgitation. So anemia can mimic any cardiac disease. Obesity, we know obesity, most of the obese people, they may have some form of dyspnea, either because of sleep apnea or because of the deconditioning. Then there is something known as psychogenic or a neurological dyspnea, And then we have something known as a physiology. Some person who is walking daily and he has stopped walking, he may get deconditioned. So that is known as physical deconditioning, which may cause dyspnea. Now there are various dyspnea mimickers also, which is actually not dyspnea, but it mimics a dyspnea, which I'll come to it in some extra slides. Now, before going to the important is any cardiac disease can cause dyspnea. So the dyspnea is the symptom of almost every cardiac disease. So the first important thing will be a coronary artery disease. And when does a coronary artery disease cause dyspnea is the most important cause is raised left ventricular end diastolic pressure. So the cause of dyspnea in a coronary artery disease is usually left ventricular end diastolic pressure rises, which causes a raised left atrial pressure, which cause pulmonary capillary wedge pressure and cause dyspnea. So this is how coronary artery disease cause dyspnea. Now next is valvular heart disease, predominantly stenotic. Now this is the most important thing which is you should remember. The stenotic lesion, dyspnea is the most common symptom. Regurgitant lesion, fatigue and palpitation is the most common symptom. And among those also, if patient is mitral regurgitation, the most common symptom, if they ask you, it is the fatigue. Why? Because all the blood from LV is going to the LA. So the effective forward cardiac output, the word is effective forward cardiac output is reduced in mitral regurgitation. And so they have fatigue as the predominant symptom. Whereas in aortic regurgitation, because the heart is very big and there is so much regurgitant volume is coming, the palpitation is the predominant symptom of a aortic regurgitation. And the stenotic lesions, the mitral stenosis. Now, very important thing is why mitral stenosis cause dyspnea. It is not because of raised LVEDP, unlike in aortic stenosis where there is a left ventricular hypertrophy which raises the LVEDP. In mitral stenosis, because of the mitral stenosis tight valve, the LA pressure increases, and because the LA pressure increases, it reflects as a passively into the pulmonary capillary wedge pressure, which causes dyspnea. That is why dyspnea in a mitral stenosis, it occurs very fast as compared to aortic stenosis, where you tell that if the dyspnea occurs, it is very late stage. So most of the aortic stenosis are usually asymptomatic till the late phases, unless they develop dyspnea, which means that either a diastolic dysfunction has occurred or a systolic dysfunction has started. Now, cardiomyopathy is one disease, as I told you, dilated cardiomyopathy, hypertrophic cardiomyopathy. The most common symptom is dyspnea, again because of the raised LV and diastolic pressure. Congenital heart diseases. Now, this is one thing which I am going to discuss in the next few slides. Congenital heart diseases like ASD, VSD, because of hypoxia and because of the so much RARV dilated blood goes to the lungs. That is one reason, and for them to have dyspnea, and because of they have ventilation perfusion mismatch. Other causes of dyspnea in congenital heart disease like cyanotic congenital heart disease, where there is a right to left shunt. Because of the right to left shunt, hypoxia occurs. Hypoxia occurs, hypercarbia occurs, which activates the chemoreceptor, which increase the work of breathing and cause dyspnea. So that is the cause of dyspnea in cyanotic congenital heart disease. Pericardial diseases like the constrictive pericarditis are usually may present with dyspnea because of the reverse Burnham phenomena most of the time. Pulmonary embolism, because the effective forward cardiac output is reduced. In pulmonary embolism, we know because severe PTE, effective forward output, cardiac output to is reduced, and so that causes decreased blood flow to the skeletal muscle, and that skeletal muscles are usually have afferent receptor. They have an afferent receptor, AFF, not efferent, and that cause the increased work of breathing. Pulmonary hypertension again is same mechanism. Here the ventilation perfusion VQ mismatch occurs, which causes dyspnea. And right heart failure, there are, I'll come to the next slide. There are various causes of right heart failure which can present with dyspnea. I think this is one slide where I have told you clearly all the cardiac diseases and how they can cause dyspnea. Now coming to the mechanism. Now this is one question which I think they will invariably ask you. That is the mechanism of dyspnea. In a broad or in a nutshell, you should remember that there are three types of receptors: mechanoreceptors, metaboreceptors, and chemoreceptors. Now, the most important of this are the chemoreceptors and the mechanoreceptor. Now, your most common Viva question is always they will ask you why LVF or a left heart disease causes dyspnea, because they have something known as the mechanoreceptors. Now, they are mechanical receptors which are activated by any stretch. So the most common are the J receptors, which are present in the alveolar interstitium. So any patients in CCF, when there is a volume overload in the lungs, it stimulates the J receptor, which is the afferent. It goes to the sensory cortex, and there it gives the feeling of increased work of breathing, and so the patient develops dyspnea. These receptors are also present in the upper airway and in the lung and in the chest wall. That is why even in patients with bronchial asthma, COPD, pleural effusion, they can have dyspnea via the mechanoreceptors. You should always remember. Next is the chemoreceptors. Now the chemoreceptors usually are activated by hypoxia, hypercarbia and acidemia. Any metabolic acidosis, respiratory acidosis, hypercarbia and hypoxia. Chemoreceptors are present in the carotid bodies and in the bifurcation of common carotid artery. So here it again, they are the afferent signals. They usually go to the brain in the sensory cortex, where there are efferent signals, and they cause the increased work of breathing. And the third is the metaboreceptors, which we discuss very less. But in a patient with the pulmonary artery hypertension and all, in the pulmonary vascular bed or a pulmonary vascular receptors, they are known as metaboreceptors. Any response to hypoxia or hypercarbia, they are usually activated. So these three receptors are the afferent, 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 which goes to the brain, and there they have efferent receptors in the sensory cortex. Now, the most important mechanisms are these three mechanisms. Now, there are some other postulates which are actually not very definite, are something known as the afferent, reafferent and efferent mismatch. This usually happen in COPD and asthma, but the exact mechanism is usually not known. So it is known as the afferent, reafferent mismatch. And there is also something known as the length tension theory by Campbell and Howell. But if you remember the first three mechanism and connect it to various cardiac and pulmonary diseases, it will be great. So because that are the main three mechanism, and that is what is given in your Harrison. Now, as I told you, in how does cardiac disease cause dyspnea? Left heart disease, there is only, most of the time, there is one mechanism, which I told you, J receptors. When it comes to right heart disease, there are various right heart disease like pulmonary embolism, pulmonary hypertension, cyanotic congenital heart disease, restrictive cardiomyopathy, constrictive pericarditis, right ventricular MI, RVMI. So these are the various diseases of right side which cause dyspnea. How they cause dyspnea? I told you, because the RV cardiac output is less in pulmonary embolism, in PAH, it causes the decreased blood flow to the skeletal muscle, and fatigue of the respiratory muscle. They have afferent pathways which goes to the sensory cortex, which have efferent pathway, and it causes the increased work of breathing. That is the most common thing, that is the fatigue and decreased cardiac output. Now second important thing is, if the blood flow to the lungs are less in right side heart disease, the perfusion part is low, and then it has to match by increasing the ventilation. The V of the VQ increases, and so the work of breathing, patient hyperventilates. So there, that is known as the VQ mismatch, and that is known as the increased work of breathing. Also, we know that the dead space is increased, and that is one important thing. And then we know any right heart disease can cause reverse Burnham, that is the shifting of the septum towards the left. So when the septum shifts towards the left, the LV cardiac output is reduced, and that is how the patient may feel the dyspnea. Also in cyanotic congenital heart disease, as I told you, there is a full cycle, that is a cyanotic spell, where because of the increased venous return, there is a right to left shunt, which causes hypoxia, hypercarbia, which again activates your chemoreceptors and metaboreceptors, and that cause the increased work of breathing. So these are the various causes of dyspnea in a cardiac disease. I think I am clear in that. If any doubt, I'll take it later. Now, as I told you, you have to always ask a clear history of dyspnea. It is a dyspnea or a mimicker. Now, before going to that, there are various dyspnea mimickers I'll go to. So if a patient has present with dyspnea as an anginal equivalent, we know there are various anginal equivalent, we know that males usually present with typical angina. It is the females who usually present with anginal equivalent like the fatigue or the dyspnea, or it will be diaphoresis or exertional syncope sometime. So these are various anginal equivalent. Usually we see in a diabetic ketoacidosis and a CKD patient, if a patient has acidotic breathing, they usually, we feel that it is a dyspnea. A young female or a psychogenic hyperventilation, it may mimic as a dyspnea. Anxiety or hysteria can present with dyspnea, can look like a dyspnea. Also, a central neurogenic hyperventilation can mimic a dyspnea. Pregnancy, in many pregnant women, when they have a volume overload and the stroke volume is increased, they may perceive dyspnea, which may not be a true dyspnea. Fever can sometimes may have a dyspnea. Septicemia, we know sepsis can cause acidotic breathing or itself can cause a dyspnea. And a protracted cough, the patient may have a feeling of dyspnea. So these are the various dyspnea mimickers which you should know. Then, as I already discussed, whether it's a cardiac cause of dyspnea or a pulmonary cause of dyspnea, you should always see. So, the various things which tells that it is a pulmonary cause is cough with sputum or without sputum, a history of wheezing is there, it is related or unrelated to exertion. Usually the respiratory things may be related or may be unrelated to exertion. If the patient gives a pleuritic type of chest pain, you should always be able to differentiate a pleuritic type of chest pain. And if a history of loss of weight is there. So these are the things which may tell that the underlying pulmonary cause of dyspnea may be there. However, if the patient gives a history of orthopnea, PND, and very other typical history associated with heart disease, or gives a brown cardiac asthma, brown frothy expectoration with wheezing, then it may be underlying cardiac cause. Seasonal allergy goes for a respiratory things. If the symptom is not acute, it progresses over years, then it may tell that it may be a pulmonary cause. Bronchi, decreased breath sounds, barrel chest, decreased air movement. So examination, I won't go, but respiratory has a long list of examination finding. However, a coarse crepitation goes more in favor of pulmonary as compared to a fine crepitations and a murmurs and other finding which go for a cardiac cause. Now, response to oxygen is one important thing for a pulmonary cause, which usually doesn't happen in a cyanotic congenital heart disease, usually where they use cardiac cause usually respond to diuretics and various other the most common not a bedside investigation to differentiate a cardiac and pulmonary causes NT-proBNP. The one marker which may be able to differentiate and tell that it is not heart failure is NT-proBNP. Any value more than 450 or 300, if it is abnormal for a patient who is less than 50 years, and you can tell that it is a heart failure and not a pulmonary cause of dyspnea. Now, also you should grade the dyspnea. Now, I will come to grading. Now, I won't go to the MMRC grading of dyspnea, because this is what you will be reading in your respiratory classes. But the most common score which we use in our cardiac thing is NYHA. Now, NYHA does not only tell dyspnea, there are 4 cardinal symptoms which it assesses: dyspnea, palpitation, fatigue, fatigue, and chest pain. So all these 4 symptoms can be assessed by NYHA. Now, I hope by now that you know the NYHA classification, but I will just tell once that you should always tell that the patient with underlying heart disease. So NYHA always happen in a patient who has an underlying heart disease. Second line is palpitation, fatigue, dyspnea, and chest pain. Now, NYHA class 1 is does not cause or obstruct the ordinary physical activity. Patient is able to do all the ordinary physical activity. Class 2 is slight limitation of physical activity. Class 2. Class 3 is marked limitation of physical activity. And class 4 is dyspnea even at rest. Now, slight and marked is something which you may not be able to tell and the patient may not be able to tell you. That is why NYHA has added 2 more things. That is, ordinary physical activity cause dyspnea, which is class 2. So if a patient ordinary physical activity, like if a patient is going to work and all, his work things are causing dyspnea, it is NYHA class 2. Less than ordinary physical activity, like the home things, bathing, combing, changing clothes. If that is causing dyspnea, it is known as NYHA class 3. And dyspnea at rest is NYHA class 4. So this is how you have to quantify the dyspnea. Not only dyspnea, chest pain, fatigue, and palpitation. So you should always remember, but there are limitation to NYHA is that it is subjective. Second, it is not reproducible. One, it is subjective, it is not reproducible, and that is why the sensitivity and specificity or NYHA classification is very low. That is why in heart failure now people have come with the staging, stage A, B, C, and D, where in NYHA the patient may go from one NYHA to other and may come back from one NYHA to other. However, in the stages of heart failure, the patient once he goes to class C, he can never be class B. So he can only go ahead, we can never come back. That is why the staging of heart failure has come. Now, after NYHA, the Goldman specific activity scale. Now, this is something which is not very important, but if somebody asks you, it is based on metabolic equivalent. It is known as METS, METS. METS is metabolic equivalent. One MET is the amount of oxygen consumption needed to do that work. So we usually, the home activities, what we do are usually 4 to 5 METs. Cooking, taking bath, combing, wearing clothes. 5 to 7 is if you're farming or gardening and all those things are 5 to 7 more, or you're riding a bicycle. More than 7 is high activities like basketball, baseball, playing cricket, or for high speed cycle, running and all. Those are more than 7 metabolic equivalents. So Goldman specific activity more than 7 METs, if the patient is able to do it, is class 1. 5 to 7 is class 2. 2 to 5 is class 3. Less than 2 is class 4. So this is how, but if you remember, it's fair enough. However, otherwise it's also okay, I feel. Then there is something known as visual analog scale. This is not commonly we use, but you should always remember at a grading of 1 to 10, you can quantify the dyspnea. Not only dyspnea, there are various things like chest pain and all, which can also be graded in a visual analog scale. And last is WHO classification, that is done only for pulmonary artery hypertension. If a patient with pulmonary artery hypertension presents with you, apart from NYHA, you can also use the WHO classification. Now, one thing which you should remember is it is exactly same as NYHA. Only thing is in NYHA, the fourth symptom, which is palpitation, is replaced by Syncope in WHO classification. All other symptoms are same. However, palpitation, instead of palpitation, we use syncope in WHO classification. All other things are same as NYHA. So once you have classified the graded the dyspnea, next important thing is orthopnea or PND. Now, how do you define orthopnea? Now, orthopnea is usually defined by, the dyspnea in lying down. Most of the people, when I ask them, they usually tell orthopnea is usually the dyspnea in lying down position. It is not only the dyspnea in lying down position, it is the dyspnea in lying down position which gets relieved by sitting. So if somebody asks you the definition of the orthopnea, never tell dyspnea in lying down position. It's a dyspnea in lying down position which gets relieved by sitting. That is how it's defined orthopnea. Now, what are the various mechanism? I think by now most of you will know the mechanism of orthopnea. On lying down position, the venous return increases. It increases the left ventricular cardiac output. It increases the pulmonary capillary wedge pressure or capillary congestion, activates the J receptor and cause dyspnea. This is the first mechanism and the most common. Even if you remember, it's well and good. The second is pulling up of the diaphragm. That when the diaphragm pulls up or pushing up of the diaphragm, it is caused the orthopnea. Now, various causes. So orthopnea is not sensitive for left heart disease, or it is not sensitive for cardiac disease. Apart from the cardiac disease like LV failure, there are other disease, right heart disease like constrictive pericarditis, which can cause orthopnea. Then pleural effusion can cause orthopnea. Ascites by pushing the diaphragm can cause orthopnea. Bilateral diaphragmatic paralysis by pushing the diaphragm can cause orthopnea. So these are various causes of orthopnea: pleural effusion, ascites, diaphragmatic palsy. So these are various other causes of orthopnea. Mechanism I have already told you. Now, whenever you ask a history of PND, you should always means you ask for orthopnea, you should always tell about PND. Now, PND, as I already tell you, what is PND? They may tell you to define the paroxysmal nocturnal dyspnea. It is dyspnea in which occurs 2 to 3 hours after the patient goes for a sleep, and the patient may feel air hunger and cough with expectoration, which may wake him up from sleep, and so he may go to a window and puts his leg down to get relieved. So this is how you have to ask the history. So always remember, a patient will only have one episode of PND in a night. You can never have more than one episode of PND, because once he goes to sleep, he will never be accustomed, and then he may be scared to go back again to sleep. So only one episode of PND can occur at a time. However, this is one thing which should be differentiated from a asthma, because usually the asthmatic attacks usually occur in the early morning, 4 o'clock or 5 o'clock in the morning, and this is how you differentiate it from PND, which occurs at around 12 to 1 a.m. Now, one important thing which important is mechanism. Now, most of you will be wondering why it takes 2 to 3 hours, and that is the mechanism of PND. The mechanism of PND is the redistribution of fluid from the interstitial to the intravascular apartment. So whatever fluid was there in the interstitial apartment, it goes to the intravascular apartment, and this phenomena takes 2 to 3 hours, and that is why PND takes 2 to 3 hours. The first important mechanism is this redistribution of the fluid from the interstitial to the intravascular compartment. The second mechanism will be decrease the sympathetic drive. The LV sympathetic drive is decreased. The third mechanism is the respiratory drive. The respiratory drive is decreased. Then fourth mechanism will be a nocturnal arrhythmia. So these are the various mechanisms, but the first thing you should always remember is the redistribution of fluid, and then your sympathetic activity is decreased, respiratory drive is decreased, the REM sleep may be increased, and the nocturnal arrhythmias. Now, there are various mimickers of PND. As I already told you, cardiac, apart from the PND, bronchial asthma can rarely mimic as PND. Post-nasal drip can mimic as a PND. OSA, obstructive sleep apnea, can mimic as a PND. GERD, they may mimic as a PND. So these are the various mimickers of PND, like GERD, asthma, obstructive sleep apnea, and post nasal drip. So you should always remember the PND and its mimickers. Now, there are two other things which I think you should know, because many people may ask you, is tropopnea. Tropopnea is lying to either left dyspnea in right or left decubitus position. I think most of the patients you would have seen bedside, patients with gross or massive pleural effusion of one side, they are very comfortable lying to that side. So that is known as tropopnea, either a right or a left pleural effusion. Now, that is not the only cause, but that is one of the most important cause. But you should always remember that a patients with cardiac failure, CCF, can also have tropopnea. Patients with cardiac tumors can have tropopnea, or a mediastinal tumors or intracardiac shunts. But the most important thing which you should remember is massive or gross pleural effusion. Now, platypnea is what is the reverse of orthopnea. Now, you would have heard many times platypnea, orthodeoxia syndrome. So platypnea is dyspnea in upright position. When the patient stands, he will get dyspnea, and it can be because of intracardiac shunts or extracardiac shunts. Now, intracardiac shunts like atrial septal defect or patent foramen ovale. These are the various things which may cause platypnea. Why? Because when they stand, there is an increase right to left shunt. The shunting may increase, and that may sometimes may cause dyspnea. Apart from this, the extra pulmonary, these are the intracardiac, the extracardiac shunts, and these are like the pulmonary AV malformation or a pulmonary AV fistula. They usually cause platypnea. So when the patient stand, he may not only have orthopnea, platypnea, he may have the resting saturation may come down because of the PFO. So platypnea, orthodeoxia syndrome, you would have heard in your gastroenterology classes that hepatopulmonary syndrome in cirrhosis. So hepatopulmonary syndrome, by opening the AV malformation, which is an extra cardiac shunt, it can present with platypnea. Apart from intracardiac shunt like a ASD or a patent foramen oval. One of the other important cardiac cause of platypnea is we always known as a ball well thrombus or a myxomas, left atrial myxomas and all. They usually may present with platypnea. So that is one important thing which I think you should always remember. So I think this is what I have covered about the PND and orthopnea. Now, whenever you ask a history of PND orthopnea, the next important thing, I think it is mostly relevant to mitral stenosis or the hemoptysis. You should always ask a history of hemoptysis. Now, why cardiac disease or typically mitral stenosis cause hemoptysis is there are 5 or 6 important causes. The first cause which you should always know is pulmonary apoplexy. It is because of the increased pressure, it caused the rupture of bronchial collaterals, which cause hemoptysis, also known as pulmonary apoplexy. Second thing is when there is acute decompensation, acute pulmonary edema may present with blood frothy sputum, and that is hemoptysis. Winter's bronchitis in mitral stenosis, because of the recurrent secondary infection and the mucus plug, it may present with winter's bronchitis, also known as also cause hemoptysis. Fourth is pulmonary infarction, which we know can cause with hemoptysis. Patient who is on warfarin or anticoagulation may present with hemoptysis, and end stage mitral stenosis may cause hemosiderosis, that is the calcification in the lung parenchyma, which may present with hemoptysis. So I think this 4 to 5 causes you should even tell very clearly when they ask you the causes of hemoptysis in patient with mitral stenosis. Also, patients with cyanotic congenital heart disease also have hemoptysis, where the causes remain same, where the collaterals, MAPCAs, which we call it, autopulmonary collaterals, underlying infection, or the rupture of bronchial veins, or a polycythemia may cause a hemoptysis. Pulmonary infarction may cause hemoptysis. Also, cyanotic heart disease, they have platelet disorders or coagulation abnormalities which cause hemoptysis. So hemoptysis is an important symptom. Also, which I have not discussed, is a Ortner syndrome, that is the hoarseness of voice. Now, you should always ask in a history of a patient with mitral stenosis the hoarseness of voice. Why? Because the recurrent laryngeal nerve may be compressed by one, the dilated left atrium in mitral stenosis, or the dilated pulmonary artery in mitral stenosis, or the tracheobronchial lymph nodes in mitral stenosis. So these three things can compress the recurrent laryngeal nerve, and which may cause the hoarseness of voice, or what is known as Ortner syndrome. Now, if any, I would like to go a little slow. So if any questions are there on dyspnea, you can ask. I'll take a break of 2 minutes. Any questions, I'll take it.
Hello, sir.
Yeah.
Sir, I just needed to know, like, sometimes they ask in Vivas if you have to name just one test to distinguish between cardiac and respiratory cause of dyspnea, what would that be?
You can tell it a BNP or a NT-proBNP.
Thank you.
I think we have stopped using BNP now, most of the people, where the cutoff of BNP was 100. Anything more than 100 was abnormal. Now NT-proBNP has come, which is age related, like less than 50 years, 50 to 75, and more than 75. There are various cutoff. So you can tell the cutoff is 300 overall for a NT-proBNP. Anything more than 300 is abnormal.
Thank you, sir.
Any other questions? I'm going a little slow, so you can ask the questions. Sanket, anything?
No, I think anti-pro-BNP makes a lot of sense now, but I think last 4 or 5 years back, we still used to take it cardiorespiratory exercise test or breathing test, which used to differentiate between cardiac and non-cardiac, and I think it is described in somewhere in Macleod's, or I have to see whether it's in Davidson Harrison. They've given the
Yeah.
cutoff with this much activity. If heart rate is this,
Yeah,
it is
right.
likely
If
to
that
be
is
cardiac.
VO2 that
Okay.
can actually get it. But now we have a easier markers, na?
Yeah.
Just one blood marker which can differentiate. But that is also not very, because there are many false positive things which can cause false positive NT-proBNP, like CKD, sepsis, arrhythmias, cardiomyopathies. So there are various things which can cause false positive NT-proBNP level. So you should always take it in the setting of a underlying condition.
So, but we can at least tell it has good negative
Yeah,
predictability,
yeah,
right?
yeah. It
If
has
it
good
is less
negative
than
predictive value. Yeah,
100,
yeah.
it is like
Yes, yes.
unlikely to be cardiac. That's how I will take it. If it's high, then there can be
Right,
multiple
right,
things.
right.
Yeah.
So no other questions. I'll move to the next symptom.
Sir, while presenting the case, if suppose orthopnea is present, then we need to mention regarding PNP is not there. Like both we have to specify, sir, or only
Yeah. This is
orthopnea?
one important thing. See, you should always remember it is the PND which comes first and then the orthopnea. It is not the, many people think it is the opposite way, that orthopnea comes first and then the PND. It is the PND which comes first and then the orthopnea. It is your talent to extract a history of PND, and it is patient's talent to give a history of orthopnea. So orthopnea, you will invariably get 99% of the time. There is no doubt. But PND is something which patient may not tell you. You have to extract that history. So many a times, even if PND is there, you may not able to extract it. So that history is important. But orthopnea, if it is there, I think that is fair enough. But PND, if it gives, then you are very definite it is a left heart disease.
Okay, sir.
Now there is one more entity which I don't know it's there in brown world. I will just discuss is a bendopnea. So which is coming in last few years. On the bending down position, the patient gets dyspnea. See, that is very common thing which happens to most of us. When we bend down, there is a decrease in the, means it compresses the intra-abdominal structures, and that causes dyspnea. But when a patient comes with you and tells that whenever I bend down, there is a bendopnea, there's something which you should always think that there is some right heart disease or a pulmonary artery hypertension or a right heart failure, incipient right heart failure. You should always rule out an incipient right heart failure when you get a history of bendopnea. So bendopnea is something which you should remember. So I'll proceed. I think I'm
Yeah.
going little
So
delayed. Yeah.
yeah, no problem, Dr. Sudhakar. Time is always cool.
Yeah.
We won't push it.
Yeah.
One more point I will like to tell to our students. What Dr. Sudhakar has discussed about dyspnea, there are lots of Viva question which has been covered in this. So we will have a recording. You can re-listen and note down as per things, and we will try to arrange these things in notes. Already I have shared one cardiology note. I will reshare it, but we will try to rearrange few things which is I have not mentioned in my notes which I am learning today. So we will add it, and we can do that. So that will be definitely a part. So you just start noting down the questions of Viva point, and you will definitely have explanation with the video, and we will try to make it in the hard copy also. So that will be done once our class is over. And any doubt you can definitely ask. Someone is spelling it is going fast, definitely can tell us to be slow. Time is one thing at least we have, so we will definitely cover it. Because today Harrison, I am not going to push much. I will discuss 4 chapters that will be taken care. So let's go ahead with the Sudhakar sir's next topic.
Okay.
Yeah.
So the next important thing is chest pain. Now, that is something which we encounter, you encounter, everybody will be getting also some atypical form of chest pain. Now, most of we will have some form of pain in the overall precordium, and we think is it significant or not. And the same happens to a patient also. A patient comes to my OPD and tells, I have chest pain. Right from a 18-year boy to a 70-year male may come with chest pain. And 18-year boy, I will just discard the finding. Oh, it is a 18-year boy. Why he should have chest pain? Why he should have a coronary artery disease? So first important thing is you have to tell whether a chest pain is angina or not. Now, a chest pain can be angina or it can be a non-anginal chest pain. Angina only we take it in with related to coronary artery disease, and all others are non-anginal chest pain. So when you define angina, I just for your note, the term angina was first given by Harborden. He has many other things to his name, Harborden notes and all, and it is not Levine. Many of you will tell that Levine because it's a Levine sign, so it was given by Levine. It is Harborden who coined the term angina. So there are before I would first like to introduce the term angina. So when do you call it a angina or a typical angina? We know there are 3 points, 1, 2, 3. So the first point is it is a retrosternal pain. The always remember first point is a retrosternal pain. And what type of pain it is? It is a stabbing pain, or it is a piercing pain, or it is so it's a stabbing type of pain, it is a piercing type of pain. It can never be a pricking type of pain, or a burning type of pain. It can happen, but it is usually a stabbing or a piercing type of pain. Point two is how it is precipitated. It is precipitated by usually exercise, anginal pain. And third is how it is relieved. It is relieved by rest, and it is relieved by nitroglycerin. So if a patient has all these 3 points, 1, 2, and 3, it is known as typical angina. So now we are talking about the stable angina, chronic stable angina, where the patient has angina history for more than 2 months. So if the patient has chest pain retrosternal, which is increased by exercise and decreased by rest, he has a typical angina. If out of this 3 points, only 2 points are met, only 2 points are met, it is known as atypical chest pain. It is known as not atypical angina, it is atypical chest pain. And if the patient has only 1 point out of the 3, it is known as non-cardiac chest pain, NCCP, or it is also now called non-ischemic chest pain. So if the patient has only 1 point, it is known as non-ischemic chest pain or non-cardiac chest pain. Now, apart from this 3 point, you should always know the pain of cardiac angina can go anywhere from the jaw to the umbilicus. He can have some patient even present with teeth pain, jaw pain, left hand pain. The patient with left hand pain and can also present with right hand pain, though the sensitivity of right hand is little lesser compared with the left hand pain. He can have the associated with sweating and all. So this is how we define the chest pain and also angina. Now this is what is angina. Now there is something known as unstable angina. Just for your knowledge, not related clinically. Stable angina is an angina which is more than 2 months. Unstable is if there is a recent increase in the duration of chest pain. In the point one, retrosternal pain which lasts from 2 to 5 minutes. So any pain which is up to 2 to 5 minutes is stable angina. If it is more than 10 minutes, a pain which is increasing in duration, increasing in intensity, and it is a crescendo decrescendo pain, it becomes a unstable angina. So stable angina become unstable when the duration increase, intensity increase, and it becomes a crescendo decrescendo type of pain. And third remains your NSTEMI or myocardial infarction, where it is a continuous pain more than 20 minutes. Okay, so these are the 3 types of chest pain which you should know. Now going to the causes. Now people may ask you what are the various cardiac causes of chest pain. I made a table, but you should remember the important thing: coronary artery disease. The first important cause of chest pain is coronary artery disease. Let it be stable angina, unstable angina, myocardial infarction. Okay, these 3 things. Second is other cardiac causes, like already told you LV outflow tract obstruction because of the hypertrophy. Because of the LV hypertrophy, what happens is, first is supply demand mismatch. That is the first thing. Second thing, what happens is in aortic stenosis, because the valve is obstructed, the systolic time is increased, and diastolic period is reduced. When the diastolic period is reduced, the diastolic time coronary perfuses in diastole, and so the diastolic period is reduced, the diastolic perfusion decrease, and the patient may get angina. Third thing is, if there is associated coronary artery disease in aortic stenosis, they can have angina. Fourth thing is, they can have something known as myocardial bridging. What is a myocardial bridging is, in this the epicardial vessels run inside the myocardium, and then they are compressed by the myocardium. That is known as the bridging, which is typically seen in hypertrophic cardiomyopathy rather than aortic stenosis. And fifth is the capillary density decreases in aortic stenosis, which cause the angina. So these are the 5 causes of angina in aortic stenosis, which you should always remember. Then important is aortic regurgitation. Now I did not tell you one important history is nocturnal angina. Nocturnal angina, if a patient gives a history, there are few differential. One is aortic regurgitation due to osteal stenosis, syphilis and all syphilitic lesions or osteal stenosis in aortic regurgitation causes angina. Why? What happens during night or during nocturnal period is sleep causes bradycardia, as we all know. During bradycardia, aortic regurgitation increases, AR increases as the diastolic period increases, and AR increases, LV-EDP increases, coronary perfusion pressure decreases. We know as the corona LV endostolic pressure increases, the coronary perfusion pressure decreases. So sleep bradycardia causes increased regurgitation, which decreases the coronary perfusion pressure, and so the patient gets angina known as nocturnal angina. Apart from this, pulmonary artery hypertension can cause angina. How? One is pulmonary hypertension can cause right ventricular hypertrophy, which again cause the supply demand mismatch. Like a left side, right sides cause supply demand mismatch, and it cause angina. There is one more mechanism which I think it's is a pulmonary hypertension cause a dilated pulmonary artery, which can compress the left main coronary artery. The left main coronary artery can be compressed by a pulmonary artery, which can cause angina. And there are anemia and all can cause secondary angina. Then other diseases like aortic dissection. We know the aortic dissection can cause typically retrosternal tearing type of pain, which is maximum at the onset. It can go in the trapezius, between the two trapezius. And you should always look for signs of peripheral pulses. Right pulse will be there, left pulse will be there, lower limb pulses won't be there. So these are the typical things in aortic dissection. Pericarditis can cause chest pain. We know the typical pain of pericarditis is more in sitting position, and it decreases by lying down. Why? The pericardium comes in contact with the chest wall on sitting position, and it gets relieved by lying down. And the patient may have a pericardial rub and all. Patient may have fever also in pericarditis, but the chest pain is usually yeah. So, and mitral valve prolapse, we know that the patient with mitral valve prolapse can have very atypical symptoms like atypical chest. They can have typical chest pain also, but they usually more commonly have atypical chest pain. They have palpitations. Many patients with thin back syndrome, thyrotoxicosis, straight back syndrome, they have mitral valve prolapse, and that is how they can present with chest pain. Now there are various non-cardiac causes of chest pain. I think Sanket would have discussed, but I'll just tell gastrointestinal diseases like esophageal spasm, GERD, peptic ulcer, duodenal ulcer, pericarditis, everything can can have a chest pain. Esophageal spasm, you should always know, is one disease which gets relieved by nitrate, like a coronary artery disease. So if a patient chest pain is relieved by coronary artery disease, by nitrate, you should always remember esophageal spasm is one important differential diagnosis. Respiratory disease like pulmonary infarction, pulmonary embolus. Small pulmonary embolism may cause peripheral infarction and can have pleuritic type of chest pain. Pleural effusion, pneumothorax, pneumonia can all have pleuritic type of chest pain. Costochondritis, herpes. Many a times we miss chest pain, and then we open the dress, and then we see many herpes zoster lesions are there. The herpes zoster can have chest pain, and so is costochondritis. Second rib costochondritis, also known as Street syndrome, can have. It is a very painful thing which takes time and all. Sometimes may react only to steroids. Costochondritis. Then chest wall myalgia, trauma can cause. And the finally is your anxiety, depression, all those types of chest pain. So I think the most common causes of chest pain I have discussed already. Now, assessment score. As I already told you, NYHA is one scale which can assess chest pain. Apart from NYHA, Goldman's, which I told you, more than 7, 5 to 7, 2 to 5, and less than 2 can assess. But the important scale is, which we use as a cardiologist in our practice, is Canadian Cardiovascular Society, CCS. So CCS uses everything same as NYHA 1, 2, 3, 4, and it is the same way you have to ask the history. NYHA1 like CCS1. So that is how you will tell that chest pain. So Canadian Cardiovascular Society scoring is one thing which you should remember. Now, next thing is some named angina. Now, there are various diseases which can have angina, like mimic angina, and one is linked angina. So, what is linked angina? Is patients with gastroesophageal reflux disease can have chest pain, epigastric pain, and that is known as linked angina. Second thing is microvascular angina. I think this is what is your most common. Your Viva question will be metabolic syndrome, syndrome X, then syndrome Y, syndrome Z. I won't go into the details. Sanket may tell you later. Syndrome X, Y, and Z. Microvascular angina is something which is related to metabolic syndrome, and they can have pain due to the ineffective microvascular tone. So that causes chest pain where the coronary arteries will usually be normal. They may have slow flow of blood in the coronary artery, and that is known as microvascular angina. Nocturnal angina, I already discussed. One important differential diagnosis of nocturnal angina you should always remember is obstructive sleep apnea. It can present with nocturnal angina because of the vasoconstriction. Hypoxia causes vasoconstriction, which can cause angina. Postprandial angina is one of the important thing, because a patient with postprandial angina, we usually tell they have multi-vessel disease. Now, why does postprandial angina happens is after a meal, the patient's all the coronary blood circulation gets diverted to splanchnic circulation, and so the patient may have angina. That is one important mechanism. All the coronary circulation is diverted to splanchnic circulation, and that is how patient may present with. And there is also the role of VIP, that is a vasoactive intestinal peptide, which may cause angina. Walk through angina. Now, this is one important thing. Walk through angina, it happens usually typically in patients with chronic total occlusion, means a vessel which is 100% occluded. Patient starts walking, he'll have angina. Subsequently, when he starts walking, the angina disappears. Why? Because there is a formation of collaterals. We know there is a natural bypass collaterals which form. So the patient starts walking, he will have angina. Once he stops walking, the angina disappears. It is known as walk through angina. And last is warm-up angina. Warm-up angina is repeated episodes of insult causes decrease intensity of angina, or the patient threshold of angina, getting angina increases. I start walking, I am getting angina. Next time I again start walking, I will get little less angina. I again start walking, I may not get angina. It is due to preconditioning. I think this is something ischemic preconditioning. The concept of preconditioning is important. So these are the various named angina. Now, many a times you will see a patient may present with a painless heart attack. Many people ask, why did not get pain? I got a heart attack. So most common, there are 3 to 4 important things. One is elderly patients. Elderly patient, because of autonomic neuropathy, that is what the most common mechanism. Because of autonomic neuropathy, they may not get. Diabetes, again, because of autonomic neuropathy, they may not get pain during a MI. Patients who are on general anesthetic, that is why most of the patient post operative may get a MI, they may not have the pain because they are on general anesthetics. And last important thing is after a transplanted heart, patient who have received a transplanted heart due to sympathetic denervation, they may not get a heart attack. So post cardiac transplant is one of the important cause of painless MI. Now, there are various diseases, valvular heart disease, which can cause angina. So in mitral stenosis, we know the causes of angina is, one is the most common cause, as I already told you, is right when PAH is there, and right ventricular hypertrophy, which cause supply demand mismatch. Second, I already told you, is a dilated pulmonary artery which may compress the left main coronary artery. Third is because atrial fibrillation is there, rarely they can get pulmonary infarction, or because of atrial fibrillation, they may have coronary emboli or associated coronary artery disease in mitral stenosis, or a low cardiac output. Though mitral stenosis itself doesn't cause low cardiac output, but they can rarely have low cardiac output, which can present with chest pain. But in a mitral stenosis, If the patient is having chest pain, it is very rare, less than 1% have chest pain. And the first diagnosis, always remember associated aortic valve involvement. You should always remember the associated other valve involvement is important. I just discussed the causes of chest pain in aortic stenosis. The same implies to hypertrophic cardiomyopathy. Supply demand mismatch, the diastolic time is decreased because the systolic time is increased. Myocardial bridging happens in hypertrophic cardiomyopathy. Coronary artery disease is there, can cause angina. Compression of epicardial vessels by the thickened myocardium and decreased capillary density. So these are the various things which cause chest pain in aortic stenosis. Again, I'll stop for a minute and take any questions if anything is there. Anybody has any questions, they can ask, because these are all the important symptoms which I don't want you to go in hurry.
Excuse me, sir.
Yeah.
Sir, can you please explain preconditioning, or will you be explaining it later anytime?
Yeah. See, preconditioning is something which is a concept which is mainly based on molecular level. Like I'll tell you, preconditioning is something you can, like most of the time we do preconditioning in an acute MI. Like suppose a patient comes, what I do is I will inflate them. They are done by various those things like ballooning. I balloon a coronary artery for 4-5 times during or I do put a sphygmomanometer around the arm for 5 times for 4 minutes for 5 times. What will happen is there are various this good things which get released in the circulations, and that cause the cardiac to have a good effect. So that is known as a preconditioning. I am again and again giving an insult, but that insult is helping the heart to have a good effects. So that preconditioning is done by various mechanisms like inflation. In usually we do in our practice by what we do is inflation of a BP cuff around the arm for multiple time, and those releases your markers which are good for the heart, and they cause the preconditioning. So preconditioning is a repeated insult which cause your good outcome, in that case decrease angina. So that is known as a preconditioning.
Okay, sir. Sir, is it the same as golf for first hole angina?
Pardon?
There's a term called golfer's first hole angina. Is this the same as walkthrough angina, where the golfer takes the first shot and he experiences angina, but while playing further shots, he'll get accustomed to the angina?
Sorry, I'm not sure. I'll also look to it. But walk-through angina is that typically you get in a chronic total occlusion of a coronary artery disease. Patient starts walking, even you will see this thing in a peripheral artery disease. I'm telling you, many patients starts walking, they will have angina and they continue to walk. And then they develop collaterals, and then their pain decreases. So this is not only coronary artery disease, it happens even in peripheral vascular disease. It is known as walk-through angina. It is because of the collaterals, the recruitment of the collaterals. Any other question? So I'll proceed with the next symptom. Sanket, okay na?
Yeah, I'm fine.
Yeah. So the next symptom, and an important symptom, is the syncope. Now this is something is one thing which comes to most of the OPDs, medicine OPD, neurology OPD, cardiology OPD, psychiatry OPD, is syncope. Now, how we do not know if the patient has a true syncope, or it is a false syncope, or it is a vertigo, or is a psychogenic syncope, or whatever. So when you define syncope, I think at our level, all of you should remember the definition of syncope, and as it is, do not alter the definition. The definition of syncope has 4 parts. It is a TLOC. I think you would have heard, transient loss of consciousness due to acute due to impairment of cerebral blood flow, loss of postural tone, and then spontaneous and complete recovery. So this 4 points are very important in the definition of syncope. It is a transient loss of consciousness which may last less than a minute or many a time less than 20 seconds. It is due to cerebral global hypoperfusion. It is associated with the loss of postural tone, and the recovery is spontaneous and it's complete recovery. It is self-limited and complete, and that is what is a true cardiac syncope. Now there are many other mimickers of syncope, like the patient may not lose the consciousness, but all the other parts of the definition will be there. It is known as pre-syncope. Without loss of consciousness, it is called as pre-syncope. Now next important thing is whether it is a epilepsy or a seizure. So you will learn it later, but that they may have many other things like a aura. They will have fits type of clonic tonic movement, tongue bite, post defecation, urination, many other things will be there, and it lasts long. And that is how we define syncope from a seizure. Now, it can be three important causes: neurally mediated, where you have various causes like the vasovagal syncope, cough, syncope, micturition syncope, many other syncopes. It can be orthostatic syncope, many other causes of orthostatic hypotension like diuretics, methyl dopa, prazosin, your ACE inhibitors, AR, angiotensin receptor blockers, or many neurological diseases can cause orthostatic diseases like Guillain-Barré syndrome, or there are many other diseases which I won't discuss. And then you have something known as postural orthostatic tachycardia syndrome. So that is a group of diseases causing orthostatic syncope. What I am more interested in is cardiac cause of syncope, because out of all, though it is not very common, it can cause a syncope. Now, among the cardiac cause, you always divide it into a patient who has a structural heart disease and a patient without a structural heart disease, like arrhythmias, brady or tachy. But the first is important is a patient with structural heart disease. So whenever a patient presents you to you with symptom, what structural heart disease can present syncope is severe aortic stenosis because of LV outflow tract obstruction, hyperdynamic obstructive cardiomyopathy because of subvalvular obstruction, massive MI, severe coronary artery disease or a massive heart attack can cause a syncope. Mitral stenosis, as I already discussed, because of severe pulmonary artery hypertension may present, or because of the atrial fibrillation can present syncope. Ball valve thrombus or the left atrial myxoma because of the low cardiac output can present with syncope. Acute pulmonary embolism, we know, because of the RV cardiac output is very low, can present with syncope. Severe pulmonary artery hypertension, again because of the low cardiac output, can present symptom. Cardiac tamponade, we know there is no filling of the ventricle, it cannot empty also the ventricle, it can cause syncope. Severe pulmonary stenosis, again because of the low RV cardiac output, can present with syncope. Eisenmenger syndrome, it is a cyanotic congenital heart disease where there is a bidirectional shunt, can cause, and rarely restrictive and constrictive. Most important is aortic stenosis and hypertrophic cardiomyopathy, you have to remember. Mitral stenosis rarely. Pulmonary embolism and PAH, you should remember, and tamponade, you should remember, which can cause. And one thing which we have not written is acute aortic dissection leading to blood in the pleura pericardium and hypotension can cause syncope. But that is not a syncope. That is not classified as a syncope. Now, how does various important cardiac disease can present syncope? Severe pulmonary artery hypertension, I told you in mitral stenosis, can cause low cardiac output and can cause syncope. Again, severe pulmonary artery hypertension, the dilated pulmonary artery can compress the left main. No blood will go to any of the left anterior descending circumflex. It may cause syncope. Atrial fibrillation may cause syncope. Associated aortic stenosis and mitral stenosis can cause syncope. If there is associated coronary artery disease, they may have syncope. And cerebral embolism can cause. It's very rare, but you should always remember, if a patient with mitral stenosis presents with syncope, two things you have to remember. One, PH, severe PH. Two, associated aortic valve disease, mainly aortic stenosis. That is the most important two things. Now, how does aortic stenosis, this people may ask you, how does aortic stenosis presents with syncope? One is fixed it is a fixed obstruction. So fixed cardiac output can cause syncope. Second is because the cardiac output is low, it activates the baroreceptor, which causes a decrease in systemic vascular resistance. SVR decreases, and so it causes syncope. Third is arrhythmias are common in aortic stenosis, which can cause syncope. Fourth is we know aortic stenosis, there is high amount of calcification which can go to the conduction system, and it can cause syncope. So these are the various causes of syncope in aortic stenosis. Now, it is not the structural heart disease which is the most common cause of cardiac syncope. It is the non-structural heart disease, that is the arrhythmias. Now, arrhythmias can be brady or tachy. Now, what is the most common arrhythmia which can cause syncope is the bradyarrhythmia. It is the complete heart block, or we know it idioventricular rhythm, or you also known as that Stokes-Adams syndrome. That is the most common thing which cause syncope. Apart from that, there is something known as sick sinus syndrome, where the patient can have sinus arrest, sinus pauses, sinus exit block, which can cause syncope. Tachyarrhythmias are less likely to cause syncope, but there are few rhythm like you may not see many cases with AF with WPW. The only broad QRS tachycardia which is irregular is AF with pre-excitation, which usually presents with syncope. Also, the ventricular tachycardia, when the patient has underlying structural heart disease, usually presents with syncope. Apart from that, usually supraventricular tachycardia like AVRT, AVNRT, they have palpitation. They usually do not present with syncope, but if they have underlying structural heart disease, they may present with syncope. And the rarely flutter may present with syncope. Now, this is one of the things which I thought is important. In a patient with syncope, what underlying things you should ask? If a diabetic patient has a syncope, always think he may have a hypoglycemia. There may be a CVA, let it be a bleed, let it be an infarct. There may be a recurrent TIA, transient ischemic attacks, or he may be on drugs like ACE inhibitor, prazosin, many other drugs which may cause postural hypotension. Even an autonomic neuropathy in a diabetic can cause syncope. So these are the important things. You should see the postural hypotension, GRBS, rule out stroke, bleed. Now, next, a hypertensive patient, again the same thing, postural hypotension, encephalopathy, high BP, hypertensive emergency, not syncope, but it may mimic a syncope, or intracranial hemorrhage may have syncope, or a coronary artery disease, or a transient ischemic attack. Same things like a diabetic. Post-op patient can develop massive pulmonary embolism and can have syncope, or during a prolonged rest, or because they are lying down for a long time, they may have postural hypotension. Drugs. Now, most important thing is you should remember the drugs which causes a postural hypotension. The most common is a diuretic. It can be methyl dopa, ACE inhibitors, hydralazine can cause, prazosin we know first dose effect. Even ACE inhibitor have first dose effect and can cause postural hypotension. After an episode of coughing, urinating is known as a situational syncope, or if people may see blood or a uneven, unpleasant sight, they may have a vasovagal syncope. If a patient gives a history of fall or a head injury, it may be due to a subdural hematoma. Now, one important thing is family history. If you are getting a family history of syncope or a sudden cardiac death, always remember hypertrophic cardiomyopathy. First important is hypertrophic cardiomyopathy before you consider arrhythmias like a long QT syndrome. A long QT syndrome may give a family history also. Brugada syndrome may have a family history because they are channelopathies. They have a family history, sodium channels and all. And arrhythmias, some arrhythmias have family history. Now, epilepsy, I don't want to tell you, you may already know, have aura, hallucinations, deja vu, automatisms, incontinence, and rarely a family history. History of peptic ulcer, hematemesis, melena, and all, abdominal pain, GI bleed. And one important thing is a deaf patient, Romanowski syndrome, you would have heard of, sensory neural deafness, and long QT. They may have ventricular fibrillation or a tachycardia. So exertional syncope is something you should ask the history patient, is it happening during walking? Then it should click your mind. It is related to the cardiac. It has to be either hypertrophic cardiomyopathy or aortic stenosis or a multivascular heart disease, multivessel disease, Pulmonary hypertension can have a exertional syncope. And one important thing is bilateral carotid stenosis. Patient may be walking, suddenly all the steel phenomena may occur and may have syncope. So this is important history. Upper limb exercise, subclavian steal syndrome, very important. Neck turning. This is one thing. Old age, 70 and more, when they are usually brushing and all, or they are turning the head to one side, they may have syncope. It is known as a carotid sinus hypersensitivity. There are various tests to diagnose that. We will discuss that later. So this is how you have to tell about syncope. Again, waiting for 1 minute. Any other questions? I would take it. I think I have already only one or two important symptomatology. So we will finish in time.
Yeah. So I think you have clarified a lot for us for cardiac. Otherwise, we discussed from Harrison properly about the syncope, and like as you told, the definition is same, and it's divided in either it's orthostatic hypotension or it's the cardiological or the vasovagal or we say neurological syncope. So I think
Yeah.
it covers a lot of things, but what he has focused for students, I think it is useful the history part. What are the association to be asked when we are getting the history of syncope? And most of the time, like what in cardiology case, like as such we know in exam, at least we are biased enough that it is cardiology case. So aortic stenosis is something we should not miss. Second is arrhythmia is something we should not miss. And third is I think clue towards the right heart failure or the pulmonary artery hypertension. These are the three major things. And four, of course, the drugs. The drugs are very common thing in comorbidity like diabetes, where you can have vasovagal kind of picture also. So that is definite. I think you can take one. We can take one or two questions. And if Dr. Sudhakar, you want to have some water for some time, it's completely fine. I am in the same way like what I take classes. It's if you need break, it's completely fine. We can take for 2-3 minutes. But then some
No, you
students, if
can. They can have any questions are there. They can ask.
yeah, definitely best. If someone has question, it will be best to discuss for 2 minutes, then to go ahead with to complete cardinal manifestation.
There are actually various syncope scores which I have not told, which I don't think so is much relevant.
Yeah.
Syncope scores, because when it is important is when a patient comes to the emergency and you have to decide whether you have to admit the patient or not, or you can send him, or what is the, or whether it is a cardiac syncope or not. So in that you should always ask whether there is an underlying structural heart disease. ECG you have to see. Most important in many cases you have to see whether there is a left ventricular hypertrophy or some mimickers of hypertrophic cardiomyopathy like apical HCM, or a short PR or a long PR, or a bifascicular or a trifascicular block, or underlying atrial fibrillation or a sinus arrest exit block. Brugada syndrome, V1 shows RBBB pattern, those type of thing. QT interval you should see, or LBBB. If an underlying LBBB is there, then you should look for a bifascicular or a trifascicular block. So these are the various things on ECG you have to see before sending a patient home. Of any patient who present, you think there is a syncope, but you are not giving much importance to that syncope. And there are various other things on like a structural echo. You can see a structural heart disease and all. So many things, or a family history. So if these things are there, the score becomes high.
Okay.
So there are scores which I have not discussed, but they are important in prognosticating and a syncope.
So I think before we move, the last class also what we discussed, the most important part of syncope is how they recover spontaneously. Like
Yeah.
most of the time, there's a confusion of convulsion or seizure and syncope. It's a recovery which makes it syncope. Self-spontaneous complete recovery, which does not happen in seizure. So again, I'm just re-emphasizing that point that if something is asked in your clinical practice or viva, that's the one point you must tell. Incontinence, some kind of movements, everything can happen in both the situation. But this is one thing, the spontaneous complete recovery, which is faster, it is likely to be syncope. So syncope patient comes to you while seizure patients are brought to you. So that's something very common, simple terms we can use to differentiate it in our clinical practice. So I think if there are no questions, let's move to the next cardinal manifestation.
Yeah. So I'll move to the next thing, which is I think is as important as is palpitations. Now, this is one symptoms which most of you have, we will also encounter, most of us will encounter, patients will encounter, is palpitation. Now this palpitation is something which we define as the abnormal awareness of one's own heartbeat, or it is also, it is actually a correct definition, nothing wrong, but this is how books define it. Palpitations are unpleasant perceptions of the heartbeat and are described by patient as disagreeable sensation of throbbing or movement in the chest. Now, there are various mechanisms. There are three important mechanisms which is alteration in heart rate, like tachycardia, SVT, VT, where the heart rate increases and that is perceived as a palpitation. Second is alteration in the rhythm. Now, patient doesn't have a high heart rate but has an abnormal rhythm like a atrial fibrillation or a ventricular ectopic beat. In the ventricular ectopic, it is the post-pause, compensatory pause. In that time, the LV end diastolic volume increases and the dimension increases and the LV contracts. So that contraction is being perceived as a palpitation or augmentation of myocardial contraction, like in anemia or thyrotoxicosis, or we know left LV dysfunction, or any congestive cardiac failure, not LV dysfunction, but a congestive cardiac failure, where we know that, or in mitral regurgitation, aortic regurgitation, where so much regurgitant volume is coming that the myocardium has to contract more to pump the blood. So these are how the patient gets a palpitation. Now, before, this is a very big table. I am more focusing on the cardiac cause, but before ruling out cardiac cause, a patient who comes to your OPD with palpitation, always you should first rule out whether it's a patient is having any anxiety attacks or a panic attacks, those things. Then you should always rule out important investigation like anemia or a hyperthyroid state, thyrotoxicosis, hyperthyroid, or in a diabetic patient, any hypoglycemia is there or not. So these are the systemic causes. If the patient is having fever, anemia, that can also cause a palpitation. There are some high outflow state like a AV fistula. CKD patient having fistula can sometimes have a palpitation. Payet's disease, which we know. Pregnant woman has high stroke volume, high cardiac output, which can present with palpitation. Then we know that there are various drugs which can cause, like if you take inhalers like a beta agonist or a bronchodilators or a hydralazine, drugs like hydralazine. I told you before only, if the patient is on a beta blocker, you suddenly withdraw the beta blocker, patient may get arrhythmias like atrial fibrillation, he may have palpitation. Both the intake of alcohol and the withdrawal of alcohol can cause palpitation, and so is cocaine, heroin, and other drugs. So there's various drug history. And then when it comes to cardiac diseases, it can be again structural heart disease, or it can be because of arrhythmia. Arrhythmia is the more commoner than the structural heart disease. But when it comes to structural heart disease, you should remember two diseases. It's the regurgitant diseases which cause palpitation because of the volume overload. I told you AR causes increased regurgitation, cause LV to contract more, and so palpitation. Mitral regurgitation, we know when the blood goes from LV to LA, in systole again the blood come back, and then you will have a palpitation. The blood during systole goes back from the LV to LA, and during diastole the LV fills, and that LV has to contract more blood. There are some congenital heart diseases. We know ASD and VSD and PDA, because the LA-LV is filled again, they may get palpitation. Even atrial septal defect, because when they developed arrhythmias like atrial fibrillation during the later part, they can have palpitation. I already discussed mitral valve prolapse can have palpitation. We know straight back syndrome, thyrotoxicosis have a mitral valve prolapse, which may have palpitation, which may have atypical chest pain. One important disease, which is cyanotic heart disease, is Epstein's anomaly, which can have various arrhythmias like a flutter, fibrillation, and they can present with palpitation. And the palpitation usually occur in adulthood in those diseases. Then rarely LV failure and cardiomegaly due to various causes can present with palpitation. Arrhythmia is the most common. The first thing which you should remember is, in a general population, it is the premature beats. You may get a premature beats for any amount, any reason. Hypoxia after a coffee, after a caffeine, anything which has caffeine. During a sleep, you may get one extra systole, and then post systole, when the LV diastolic volume increases, the LV contracts, and you may get a thump in the heart, that is known as a palpitation. regular ones like the VT, SVT, or irregular ones like the atrial fibrillation mat and the flutter with variable conduction can cause palpitation. So now let's discuss one by one. Now before that, it is one important is the age of onset. Now you encounter a young male, young person, he may have SVT. Most common is SVT in a young population, or it can be a VPCs or a atrial premature complex. Fibrillations and usually not common flutters may occur. A patient who is old and has a history of his telling, I have a history of heart attack, I have a history of rheumatic heart disease. So there, those type of things you should always remember. There may be a fibrillation or there may be a ventricular tachycardia. History wise, we'll discuss how they have, we can differentiate. Now description is one important thing. Now a patient who is telling, I get a rapid palpitation, I already discussed you, these are the history you have to ask. It is a rapid and it is a regular. We know rapid and regular is usually a sinus tachycardia, a SVT, or a ventricular tachycardia, a SVT, a VT, or a sinus tachycardia. Rapid and irregular, you remember, you know, in ECG, there are many differential: atrial fibrillation, multifocal atrial tachycardia, and a flutter with variable conduction. Only these three differential can have a irregular palpitation or irregular RR interval. Flip-flopping, you know, there is some tuck, 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 those type. They are usually due to atrial or a ventricular premature complex. Atrial does not have a compensatory pause. A ventricular premature usually has a compensatory pause. Rapid fluttering is only due to SVT or a VT. Tuck, 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 tuck. Is usually a SVT or a VT. They start rapidly. However, if the progression is gradual, tuck, 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 that means it is usually a sinus tachycardia. Now, then sometimes the patient may present with abnormal neck pulsation, not with the tachycardia. They tell, I am feeling some increased pulsations in my neck. So you should think AVNRT. It is a type of SVT where they have a frog sign. It is a sign, but symptoms wise they may have a pulsations in the neck. That is known as frog sign. That is regular. However, they can have sometimes irregular neck pulsation. That is known as a cannon AVO, which we usually get in complete heart block or a AV dissociation or a ventricular tachycardia. So we know a ventricular tachycardia usually cause fast pulsations in the neck. A complete heart block usually produces a slow pulsation in the neck. So history wise, you may be able to differentiate it by the usually it's a description. Now onset and offset, I told you, fast onset is usually a VT or SVT. Slow onset is usually a sinus tachycardia. Tuck, 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 tuck is slow onset. It's a sinus tachycardia. And offset is also, if a fast offset is there, it is usually again a SVT, usually a supraventricular tachycardia. Now, positional palpitation. Some people may get palpitation in some position, like on lying down position. If you are getting a palpitation, it is usually a ventricular or a atrial premature beats. However, if you are getting a palpitation on a, you are lying down and suddenly you are bending or sitting, usually it is usually because of a SVT. You get those palpitations. Now underlying symptoms, that is very important thing. A patient gets a chest pain during a palpitation, you should think of arrhythmogenic myocardial infarction. Also, you should also ask a history of giddiness and syncope. A palpitation associated with syncope, usually I told you, doesn't happen in a supraventricular tachycardia. It occurs more commonly in a ventricular tachycardia with structural heart disease, because they have a structural heart disease and they do not tolerate the high fast heart rate and they get syncope. Pheochromocytoma can have syncope. Hypoglycemia can have syncope associated. Also, you should ask post palpitation diuresis. This is one thing I think most of you will know, because atrial natriuretic peptide is released by the atria by usually atrial fibrillation and SVTs, and that cause a post palpitation diuresis. This you should remember, that in a ventricular tachycardia this doesn't happen. It is very specific for atrial arrhythmias. Dyspnea and all can tell the underlying LV dysfunction or a cardiac failure. Now, one important history which you should always ask is at rest or with exertion. I already told you, somebody is walking and then he's getting palpitation. It means that there is some regurgitant lesion which is causing volume overload, like a mitral regurgitation or a aortic regurgitation. At rest means arrhythmia. Just put in your mind, mostly at rest means arrhythmia, any form of arrhythmias. Psychiatric causes by underlying history you can rule out, and you should always ask the underlying heart disease of a cardiomyopathy or a structural heart disease or coronary artery disease. So this is how you have to approach the various palpitations. In a patient with palpitation, just out of topic, there are important things which you should ask is ECG. ECG is the first and the foremost thing you should do before doing a Holter or a 24-hour Holter, 72-hour Holter. And if you think there is an underlying heart disease, you should get an echocardiography done. So these are the three investigations which you should do in almost all cases of palpitation: ECG, echo, and a Holter analysis. Uh, Now, this is a very short symptom. I would like to finish it in 5 minutes. Fatigue, I told you it is a peripheral phenomena. It is because of the low blood flow to the skeletal muscle. Dyspnea, it is a central phenomena because of the central receptors. Many a times, neither the patient will be able to discriminate dyspnea and fatigue, neither you will be able to distinguish whether he's telling fatigue or he's telling a dyspnea. Even most of the time, we also can't tell that we have dyspnea or we have fatigue. Most of common cause of fatigue is non-cardiac cause. I may not go to it. You will know anemia. Any anemia can cause fatigue. Hypothyroidism, Addison's disease, hyperglycemia, hypoglycemia, hyperthyroidism can cause fatigue. Any high Cushing syndrome, many other endocrine disease presents with fatigue. Not only that, obstructive sleep apnea is one disease which may present with fatigue apart from the dyspnea. Many neurological disorders like myasthenia gravis and various other disorders, the symptom is fatigue. So fatigue has very many other differentials, but when it comes to cardiac, you should know mitral regurgitation is the most common cause of fatigue, because the effective for all the LV blood is going to the LA, so the effective forward cardiac output is reduced, which cause fatigue. Aortic regurgitation can cause fatigue, but the most common symptom is palpitation and not the fatigue in aortic regurgitation. Cardiac failure, LV dysfunction can cause fatigue. Coronary artery disease, I have already told you, anginal equivalent. Females usually have fatigue, diaphoresis, and dyspnea. Cardiomyopathies can present with fatigue. And finally, drugs like a patient who has right heart failure, cardiac cachexia, hepatic dysfunction, they have fatigue. And also diuretics, beta blockers. Beta blocker, the most common side effect, MCQ, they will always ask, is the fatigue. Diuretics, over diuresis can cause fatigue. And a fatigue in heart failure, what are the various other differential is impaired cardiac output response. As I already told you, skeletal muscle hypoperfusion cause fatigue. Cardiac cachexia, malnutrition can cause fatigue. Cytokine activation like tumor necrosis factor alpha, interleukins can cause fatigue. Anemia in heart failure can cause fatigue. Heart failure leading to depression can have fatigue. Sleep apnea is one important thing in heart failure, which can cause fatigue, and over diuresis and beta blockers in heart failure. So this can cause fatigue. So these are the various causes of fatigue in heart failure.